Good evening, everyone, and I welcome all dignitaries, MMC observer, Dr. Vaibhav Pustake from Nasi, then expert teachers, presenters, board team participants, team Maha members, team Maha Case Challenge coordinators, all Maha members and PG students as well. Today, we are in third episode of Maha Case Challenge, which has become so popular in short span of 1 month that previous both the episodes were attended by more than 1,000 pediatricians across India. All these academic webinars have raised the Maha YouTube count significantly. Now we have crossed the figure of 5,000 in subscription, and today we have 5,100 subscribers. Today we have galaxy of experts and guest of honor, Dr. Atul Kulkarni sir, who is senior pediatrician from Solapur, and Dr. S. Srinivasan sir, he is a teacher of teachers, and Dr. Sharad Agarkar sir, senior PG guide from Pune. Both are experts today. Dr. S. Srinivasan sir has joined from USA, especially for this episode. Today we have two presenters, one from Solapur, Dr. Atul Zanwar, and second from Yavatmal, Dr. Sanjeev Joshi sir. And there are two challenger teams, one from Latur IIP and second one is from Thane IIP. Today's moderators are Dr. Deepa Firke ma'am. She is from Kolhapur. She is professor in pediatrics in Medical College Miraj. And second is Dr. Anjali Gokan ma'am, who is executive board member of Maharashtra IIP and president of Palghar IIP also. So without wasting time, I request Dr. Deepa Firke ma'am to proceed further in today's session. Over to you, Deepa ma'am. Kindly unmute ma'am.
Okay, welcome everyone. So yes, we are here with one more interesting and exciting session of Maha Case Challenge. Though we had to reschedule the program because of some clashing programs with other IIP programs, but we do assure you that this will be one more exciting session with the same zeal and same thrill. So without wasting time, I request our Honorable President of Maha Dr. R.D. Patil sir, to express his views on this session. R.D. Patil sir.
Thank you, Deepa. Very good evening to all. And it is our honor that we have got one of the experts today, Dr. Srinivasan sir, as aptly told to us by Amol, teacher of teachers, very good friend of mine and a thorough academician, Dr. Atul Kulkarni, and a senior of mine from my alma mater, VJMC Pune, Dr. Sharad Agarkar sir, who is HOD in D.Y. Patil Medical College, Pune. With such a galaxy of experts and guest of honor today, as usual, with the wonderful efforts of the team of Maha Case Challenge under able guidance of Dr. Pramod Kulkarni and ably supported by Dr. Anjali Gokarna, Deepa, and Dr. Trupti and Dr. Neha Singh. And it is an honor to listen to all this Maha Case Challenge and all academic programs. Friends, even if we have got barrage of academic activities and webinars and all those things, but we look forward because we are clinicians to decode the case. We always like decoding and hunting the treasure, and all these case challenge are like decoding a case. And this definitely, I always say that we are clinically sound, but academically our pulse sometimes is 3D. And to keep our pulse bounding and hearty, we have to have such academic activities. And rather than having a didactic monologues, this case challenge and decoding is wonderful. And it will be ably supported and decoded further by our experts. Both of them are teachers, and they know how to decode this case in PG way also and in clinically also in our OPD setting. And who can be the guest of honor other than Dr. Atul Kulkarni? For every conference, we are at least seeing at least 50, 30, 25 cases which we have not seen these pictures before any presentation of him. And at the same time, I will also like to welcome and appreciate and congratulate my friend Dr. Sanjeev Joshi from Yavatmal, He is going to present one important case today, and it will be interesting also. And also, one of other presenter is Dr. Atul. Atul is Atul Dhawan. He is also going to present an interesting case. Without taking much time, I am also very eagerly waiting to hear, and we know the teams from Latur and other team which is there. The other team is from Thane. And these team members, Dr. Deepika Bhosle, Dr. Kiran Wolikar, and Dr. Santosh Bajaj from Latur, and Dr. Sudha Mudgal, Dr. Rushikesh Kunde, and Dr. Smita Patil. They will definitely decode this, and we are all very eager to listen to them and unfold this scenario and saga. Over to you, Deepa.
Thank you, sir. And I'm sure this cases and this session will have all the viewers will be having palpitation, but at least our teams definitely must have started with the palpitations. So yes, today we are privileged to have with us one dashing personality as the guest of honor, Dr. Atul Kulkarni, sir. And I request our dynamic secretary, Dr. Amol Pawar, to introduce our guest of honor today.
Thank you, ma'am. We have guest of honor, my dear friend, my mentor. He is loved all over the India for his ID knowledge. Dr. Atul Kanikar, sir, he is a consultant pediatrician and in charge NSU at Ashwini Hospital, Solapur. He is a director at Venkatesh Hospital, Solapur. He is associate professor. He is associate professor at Department of Pediatrics at Ashwini Rural Medical College, Solapur. He is a teacher for undergraduate MD, DCH, DNB and Neonatology Fellowship also. He has got various honors and he was also international faculty. He has the honor of delivering Dr. Marcus oration at Piticon, which is a Maharashtra State Skin Vedi Conference at Pune in 2011. He has the honor of delivering Dr. B.J. Krishnamurthy endowment at Karnataka State Conference in 2020. Then also rickettsial fever and Indian experiences. He has presented this at International Forum of Critical Care Medicine at Montreal, Canada in 2011. Also, he has presented the same at Pediatric Congress held at Philadelphia, USA in 2012. He has major achievements and publications. He was faculty in various state, national, international conferences. He has more than 30 publications in journals, IIP books, IIP Atlas. He was executive board member for 3 times in 2014, 16 and 19. He was vice president of Maharashtra IIP in 2007. Then he was executive board member of ID chapter also in 2020. And he was national scientific convener of clinical clue module and treat module, and he has designed various modules in ID chapter and in IIP also. So over to Deepa ma'am and Dr. Atul Kanikar sir, please have few words with us.
Hello. Welcome, Atul sir. Now I requested Dr. Pramod Kulkarni sir, who is the scientific convener for this session, to just brief the presenters as well as the teams regarding the outline and the guidelines regarding this session. Pramod Kulkarni sir, over to you.
Would you like Dr. Atul to say a word? We would like Dr. Atul Kulkarni to unmute yourself and say words of encouragement for us.
Atul sir, unmute kara.
Yeah. Thank you very much, Amol, for kind introduction. It's a really great pleasure to be here on the Maha Case Challenge digital platform. I'm really glad to see Dr. Srinivasan sir, who is a legendary person here on this platform. Namaste, sir. This is a warm regards from
Thank you. Thank you very much. Wish you the same.
Very happy to see you, sir. And always we are bless us all the new generation and young generation and all the people, because you are the legendary person in the IIP. Also, warm regards to Dr. Agar Khedkar sir. Here I would like to congratulate our dynamic president, Dr. Ramakant Patil, who has done a wonderful job in the last 1 year, last 6 months. And I was just going through the last reports of all this breastfeeding week. Every branch has doing a very wonderful job.
And oral rehydration week also. You have done wonderful work on oral rehydration also. Diary.
So very good, Dr. Ramakant Patil. So I congratulate Patil. Then about Dr. Amol, I also like to congratulate Dr. Amol Pawar. He is like a powerhouse. Always he is energetic to want to do all the things. So keep it up, Amol. You are doing a wonderful job. Dr. Pramod, you have this platform of case challenge. This is really very interesting. So many of these delegates, they are joining this program, and this is mentored by Dr. Pramod. So congratulations, Dr. Pramod, and all the team, Deepa, Dr. Anjali Madam, and all the coordinators in this team. So I congratulate all of them. One thing I want to say here that our part of the Maharashtra, there's the other, all the district, we have a very good potential of academicians. And with this platform, they are able to express here on this platform. So my suggestion for Amol is to gather good academicians, make a list of them. And my request to our president that these new academicians and who are having a good oratory, good speakers, they should be included in the state conference and zonal conference list. So this is my request to the Dr. Ramakant Patil sir, President. And with all this, I wish best luck for this program. Thank you. Thank you so much. Thank you.
Thank you. Thank you, sir, for your wishes. Now, let's move on to the session. So I first request Dr. Pramod Kulkarni sir to just brief us regarding the whole session.
Good
Over to you,
evening,
sir.
all enthusiastic attendees. I feel very proud to be part of my IPKS challenge team under the able leadership of Dr. Ramakant and Dr. Amol and my team colleagues who are so enthusiastic. I'm really humbled today to have the Dronacharya, Bhishmacharya and Arjun of IAP with us, and they are here to see our contestant doing the best clinical job to decode the cases. And to tell you, I assure you, they are going to do it, and we are very confident of it. Only request to everybody of you not to put any clues, to keep silence, to keep patience, and just look at how these people decode and how these all guides help them through and help us through going to the final diagnosis. So welcome all you, and let's proceed without wasting the time to the session. Thank you, Deepa.
Thank you, sir. So yes, we are privileged and honored to have with us two experts. And of course, we are very lucky to have a legendary personality today as an expert, Dr. Srinivasan sir. We have heard him in so many PG sessions, and we have always got many words of wisdom from him. He was a past director and a professor in Jipmar College, Pondicherry, and also an adjunct professor for the PG Nursing Institute, Chetpet, Chennai. He has a vast experience of nearly 45 years and is very well known for his work in nutrition. He's the core member of BPNI and also for the IYCF chapters. So we are very lucky to have him here, and we would surely like to have his words of wisdom for this session. Our next expert today is Dr. Sharad Agarkhedkar sir. He's a past president of IIP Pune. He's also the past HOD of DYP Pune Pimpri, and he has PG experience of nearly 35 years with numerous publications to his name. He has conducted many vaccine trials and has been known for his talks on vaccinology. Presently, he's also working as a council member for the Deccan Education Society. So I welcome you, sir, for this session. And for today, we have two energetic presenters. And for this, the first case, we have Dr. Atul Jhawar as the first presenter. He's an eminent pediatrician and a neonatologist, initially working in Dubai and now been settled in Solapur at Om Child Care Center, Solapur. So I welcome the first presenter, Dr. Atul Jhawar. Now I request our guest of honor, Dr. Atul sir, to just you can just pick up the chat and just let us know which will be the team. We have two teams here today, Team Latur and Team Thane. So you can just read out the name, which team will be facing the first case challenge. Over to you, sir, Atul sir. Atul Kulkarni sir.
Thane.
Okay.
Sir, unmute kara. हाँ, Thane. I have
So
seen.
Thane team, are you ready? Dr. Sudham, Dr. Rishikesh, and Dr. Smita.
Yes,
Okay.
we are
Okay.
Deepa ma'am, for
Yes, sir.
1 minute only. We have Dr. Vaibhav Pustake sir, who is
Yes.
the MMC observer today, and he was past secretary of Maharashtra IAP also. So, Pustake sir, kindly share your views. Pustake sir, are you there? Pallavi madam, sir आहेत ना?
हो सर आहेत सर आहेत.
पुस्तके सर बोलू शकतात?
Yes.
बोला.
Can you hear me?
Yes, sir.
Yes.
Can you hear me?
Very loud and clear, sir. Yes.
Yes. Okay. Right. I'm there. Very much there. Right. You can proceed.
Okay.
Okay,
Thank
sir.
you, sir.
Thank you, sir. Dr. Atul Jhawar, sir, are you there? Dr. Atul Jhawar.
Kindly unmute Atul, sir.
So over to you, sir. You can start sharing your screen.
Hello, good evening.
Yes, sir. So Atul, sir, you can start sharing the screen and present your case. And the team facing you will be Team Thane, Dr. Sudham Mungal, Dr. Rishikesh Punde, and Dr. Smita Patil. So I hope they are ready.
Unmute Dr. Sudham? They are not able to unmute.
Pallavi, ma'am.
Is it visible? My screen is visible to all?
Yeah, we are seeing it. Yeah.
You can start. Yeah, you have started screen sharing.
To the presenter and the teams, just a reminder that we'll be just having 45 minutes to present your case.
Madam, they are not able to unmute themselves.
मॅम त्यांचं नाव लिहिलेलं आहे का?
Dr. Rishikesh Punde.
Okay.
Tense.
Yes. Okay,
Yeah.
ma'am. Doing it.
Make it full screen.
He can unmute himself now,
Okay.
ma'am.
Dr. Atul,
Full
please
screen.
make it full screen. Go to the slideshow.
पुंडे सरांना केलं का co-host?
Yes, yes.
केलंय सर. सर सुदाम सरांचं नाव नाही दिसत आहे, ते एकत्र आहेत का?
हा, एकत्र आहेत.
ओके, येस. थँक्यू.
Okay.
So, is it audible? Am I audible and the screen is also visible?
Yes,
Yes,
you're
yes.
audible and visible. Yeah.
Yes, sir. You can start with.
We can start, no? Yeah. Very good evening to all. And in the beginning, I would like to express my sincere thanks for Maha IP challenge.
त्यांचं फ्रीज झाले वाटतं.
Atul, sir.
अतुल सर, तुमचा व्हिडिओ ऑफ ठेवला तरी चालेल जर नेटवर्कचा इश्यू असेल तर. अतुल सर गेले का?
Atul, sir.
His connection is unstable. Maybe he's coming back.
हॅलो, हा सर. मग जॉईन करा तुम्ही, पटकन तुम्हाला इन करतो आम्ही आणि मग नंतर तुमच्या एंडने He is joining in a minute.
Yeah.
Please wait.
Okay.
Anjali ma'am,
Yes.
kindly share slides from your end.
Okay.
Start sharing first. हाँ सर.
This
हाँ
way.
हाँ तुम्हाला मॅडम करतायत, पल्लवी मॅडम इन करतायत. प्लीज वेट.
सर फक्त वेटिंगला यायला सांगा त्यांना.
वेटिंगला या ना सर. हॅलो. वेटिंगला येस.
अमोल त्यांना सांग तिथेच थांब म्हणून.
हो वेटिंगला आता जॉईन करतायत ते. जस्ट ही इज प्रेसिंग.
मी आहे सर ऑन इथे आहे. झालेत ऍडमिट सर.
ओके.
झाले ना.
झालेत
अंजली
सर.
मॅडम तुम्ही शेअर करा स्क्रीन.
अतुल सर तुम्ही आले का?
जस्ट इन झालेत सर ते. अजून त्यांचा ऑडिओ कनेक्ट होतोय सर.
ओके. त्यांना पोस्ट केलं तुम्ही.
Arey, even I'm trying to share.
हॅलो.
हा सर.
Atul, you
हाँ,
can
तुम्ही
share
आले.
it.
या
You
मी
can
जॉईन
put
झालो
your-
परत. शेअर करू स्क्रीन.
Share and please put your video off.
If your
Not yet.
व्हिडिओ ऑफ ठेवा.
if your connection is poor, then you can put the video off.
व्हिडिओ ऑफ ठेवा सर. तुमच्या एंडने शेअर करा.
नाही
परत फ्रीज झाले ते.
Should we start with the second presenter?
Second
till
case.
then?
I think we'll
I
start with second case.
Yeah. I think that's better.
लातूर टीम बी रेडी.
Shall I
Latur
start?
Latur team, Dr. Deepika, Dr. Kiran Holikar, and Dr. Santosh Bajaj. Are you there?
आले एक मिनिट. प्लीज वेट मॅम. अतुल सर इज देअर नाउ.
आहे ना
अतुल सर काइंडली अनम्यूट.
अनम्यूट करा म्हणा त्यांना.
नाही ते
हॅलो.
he is frozen.
डॉक्टर अतुल
अतुल सर आवाज येतोय का आमचा? अतुल सर आवाज येतोय का आमचा?
तर सरांचं टेक्निकल होईपर्यंत नाही तर मग पुढचं हे करायचंय.
तेच मला
थांबा
वाटतं.
2 मिनिटं. तर ते मध्ये ते परत जॉईन करत राहतील. मग ते प्रॉब्लेम येईल. अतुल सर तुमचा व्हिडिओ ऑफ ठेवा. तुमच्या एंडने शेअर करायला प्रॉब्लेम असेल तर आमच्या एंडने शेअर केले तर चालेल का?
अमोल कॉल कर ना त्याला. कॉल कर. अमोल कॉल कर.
ते मध्ये जॉईन होत आहे. त्यांचं मध्ये स्क्रीन कॉल करतो.
Amol, I think without wasting time, we'll go to second.
I think that is better. Yeah.
Okay. Yes.
Better
The technical
please.
issues gets resolved. I think we should start
The
with
second team is ready.
Second team. Team Latur
Dr.
is ready.
Sanjeev Joshi.
Team Latur is ready. Let's see
Neha,
whether
can you share Dr. Sanjeev Joshi's CV slide? Okay, ma'am. Yeah. I have the great pleasure of introducing Dr. Sanjeev Joshi, our presenter for today. He is the director of Chirayu Critical Care and Joshi Children's Hospital at Yavatmal. He's also the chairperson elected in 2020. In AOP Neurology. He is the president of Vidarbha District and the chief organizing chairman of Vidarbha Pedicon 2023. He is a visiting fellow to Australia and UK and has special interest in neuro-intensive care neurology. He is ex-president of the Yavatmal branch and he's a regional trainer for NRP, ATM and AR CTM. Welcome, Dr. Sanjeev Joshi, and please present your case. And the team facing this will be the Latur team. And the Latur team participants are Dr. Deepika Bhosle, Dr. Kiran Holikar, and Dr. Santosh Bajaj. Are all three there?
Yes, ma'am.
Yeah. Please make it full screen and fever with rash. Yeah.
Dr. Deepika, you
at
all
the
three are
outset-
not well. Please come together in a single screen.
Actually, ma'am, we are trying to join from a laptop, but we're not able to join.
That's
Am
okay.
I audible?
Yes.
Am I audible?
Yes, sir. Yes, sir. Your screen is being
And
shared.
my screen is visible, I hope.
Yes, sir. Yes, sir.
So
You can continue.
at the outset, I express my sincere thanks to the most dynamic and versatile of my dear friend Ramakant, under whose leadership Maha IP has achieved a big heights. And also it is well supported by the none other than the mitochondria of Maharashtra IP, Dr. Amol Pawar, the dynamic secretary. And I am really blessed to have the experts like Dr. Srinivasan sir and Dr. Agarkar sir, the teacher of teacher, and my dear friend, the doyen of fever and rash, none other than Atul Kulkarni, who is, well, I'm really blessed to have him. Dr. Anjali, Dr. Deepa, the entire team of Maharashtra IP, you are doing a fantastic job. In fact, this is not my area of interest. I was supposed to present a hardcore neurology case, but then I thought, I gave a second thought that fever with rash is always a challenge for a practicing pediatrician. And even though it sounds very simple to look at a child with rash, but sometimes it's really a tricky business. So should I start presenting my case, madam? Thank you so much. So this was a 24-month-old male child brought by relatives. The informant, being mother, came with the complaints of alleged history of an unknown insect bite during one family function at village 8 days back, and there was some swelling and redness over the left foot. Actually, they could not identify what was the bite it was, and there was a small bite which lasted for 4 to 5 days. Responded to symptomatic treatment. They called me telephonically, the mother being a dentist, and I prescribed some symptomatic treatment for that. And then I was away from the town, so I did not have any follow-up after that. But on 23rd of the May, the child had high-grade fever with a rash, which was mainly started from the trunk and then spread it to arms on the next day of the fever only. So the mother started herself with the syrup cefodoxime, but the child did not respond till 26th. So the child was brought to me on 28th of the May with fever and rash, which was almost since 23rd of the May. So it was day 6 of the fever. The rash has progressed, and child was very irritable, not eating, so I to elaborate the rash, I asked some leading questions like whether there was previously there was any redness of palms, and so there was any swelling on the hands and feet, and then to focalize the cause of infection, I took the history to ask for some respiratory symptoms, some ear pain, then GI symptom, then any urinary symptoms. But all the child did not have any of the symptoms. There was no any history of yellow discoloration of the skin also. In the past history, there was nothing significant except he is born of an IVF after 10 years of infertility. Family history was not significant particular to this illness. The child is fully immunized as per schedule, and he has not received any immunization in the recent past. He is developmentally a normal child, growing, thriving well. So I'll just ask my colleagues, challenger. So anything you want to probe in the history further at this moment?
So, will you please, the team Latur, will you please introduce yourself with your first name? Like,
Yes, sir. So myself, Dr. Kiran Horikar. I am Associate Professor in Pediatrics, BDGM Latur.
okay.
Sir, I am Dr. Santosh Bajaj. I am Associate Professor at MIMSR Medical College, Latur.
Okay.
Sir, I am Dr. Deepika Bhuste. Practitioner.
Okay. So, pleasure having you here. So, now to summarize the history, 2-year-old, some unknown insect bite 8 years before, started fever after that, after 8 days of that bite. The bite area was totally okay. And the fever was associated with a rash. And there was no any other history, no any significant contribution from the history of present illness. How do you proceed with the history at this moment? Anybody of you can take this. Hello.
The rash after second of fever. So I would like to know what is the progression of rash, a type of
very
rash,
good. Very good.
and
Yes.
associated findings like itching.
Very nice.
Or
Okay.
there may
Okay. Okay. So
like changes.
the most important thing is the temporal relationship of fever and rash. On which day of the fever the rash has appeared. Okay. Yes. Anything else you want to the history? You are to the history at this moment.
History of
Okay,
animal.
Okay. Shall I move further?
Yes.
Okay. So on the 28th of the May, on examination, the child was awake and in the mother's lap, was irritable, toxic. Heart rate was 102 per minute. Respiration was quiet. Temperature was 100.5 degree Fahrenheit in the axillary area. Saturation was 99 on room air. Blood pressure was 90/54 in right sitting position. On examination, there was a mild pallor, no icterus. Throat was absolutely normal. Ear examination was normal. Eye showed mild conjunctival injunction. There was a single lymph node, not actually in the anterior triangle, but more so in a left supraclavicular region. Extremities were normal. The bite area was normal. There was no issue. I couldn't localize any issue. And coming to the rash now, it was a maculopapular erythematous rash. In some areas it was confined, some areas it was discrete, involving cheek, also involving chest and abdomen, also involving upper and lower limb, but it was sparing the palms and sole. So this was a typical description of the rash. So anything you want to add in the general examination before we go for the systemic examination? Anybody of you?
I would like to know the eye condition.
I already have mentioned there was a mild conjunctival injunction.
Okay.
Yeah. Anything else?
Tongue, how was the tongue?
Sir, throat examination is totally normal. Okay. Already mentioned. Anything else?
Dr. Pramod Kulkarni has requested the team to make some guesses or some differential diagnosis on the presentation so far.
So would you like to elaborate the rash further, like any other morphology of the rash, like any associated purpura, any associated perineal rash? Okay.
Any disclamation?
Yes, any disclamation? Would you like to probe in the, would you like to see for any disclamation, any nail changes? Yes?
Yes.
Okay, so this is the way you approach this child who had a maculopapular erythematous rash, almost symmetrical, progressing from trunk, from cheek to the extremities. Perineal area was not involved. Nail beds were normal. There was no discommission. And except for a solitary lymph node in the left supraclavicular region, there was nothing. Throat examination was not contributed. So we moved with the systemic examination. CVS was almost normal. Chest examination was also normal. There was no added sign. Entry was totally normal. For abdominal examination, it was non-tender, soft abdomen, and I could not appreciate any organomegaly on 28th of the May. CNS child was awake. There was no meningeal sign, no focal deficit, no cranial nerve palsy, but the child was irritable. So we decided to admit the child for further workup and treatment. So just look at the pattern of the rash. So anybody can describe this rash now? Anybody of you?
Erythematous micropapular
Okay.
rash with at some areas it's like a confluent, some it is like a spared.
Okay. Okay. So I already told you the rash was not involving palms and soles. Okay, anything you want to add? Okay, nice.
Team Latur, can you make some differential diagnosis?
So
based
now
on-
the gentlemen, the thought process for any differential, anything you want to add to the examination? And before going to workup, anything you want to add to examination of this child? 2-year-old, irritable, erythematous, maculopapular.
Sure.
rash.
Okay, thank you.
Yeah.
Lymphadenopathy is there.
Lymphadenopathy is there, yes.
Any signs?
Ishar we have looked for, it is not there. The bite area was normal. Anything more specific would you like to? Any thought process or what differential you would like to put at this particular point? Would you think this is an infection? If it is infection, it's a viral infection or a bacterial infection. And if it is non-infective, what are your 1, 2, 3 choices for non-infective? Now,
Sanjeev sir,
would
Sanjeev
you go?
Sanjeev.
Yeah.
Srinivasan sir.
Can I
wants
ask
to-
one question? As an
No,
expert,
sir,
can
please,
I add
Sir,
to
it
point?
is a great pleasure to have.
No. I
Srinivasan
just
sir.
wanted to ask the three people whether do they like to see specifically in the skin one area, which is very well described. He mentioned about the anus and okay, but anything else you would like to see in a particular area in the arm?
Yes, very good. I was about to that, sir. I was
Sir has
about
given
to
the
that.
clue. Sir has given the clue.
Srinivasan sir has given the clue.
I am in a place where deer is there, and both my daughter and this thing they had rashes, and it was Lyme's disease due to tick bite.
Yeah.
Latur team, you are already given a clue. Can you have some guesses?
बंद करा
It's a
नहीं है
direct clue.
ए मला पाहता हे मीटिंग चालू आहे
Yes,
Latur team, any one of you?
Team
Sir has
Latur.
given a good. Sir has given you a very good clue.
A straightforward clue.
Rat bite.
We have infective disease differential diagnosis like rickettsial.
Okay. So just tell me whether you are thinking in terms of a viral one or a bacterial one or a rickettsial one. Like first, would you exclude viral exanthema at this particular moment? Are you thinking in that particular direction?
Yes, looking at the pattern of fever and rash, viral infection can also be picked up as a DD.
Okay. Which particular viral infections you are thinking about? Yes, anything from anybody from Latur?
Dengue-like illness.
Very good, very good. So we are thinking in terms of arboviral infections like dengue or chikungunya, like okay. So what are the points in favor of a dengue-like illness in this child, or what are the points against the dengue-like illness in this child?
Basically, the fever is immediately followed by rash. There is no flushing of the extremities. There is no redness of palm and soles, as well as the typical appearance of the fever, relation of fever. So at least after second week, fever should disappear.
So very good. So rash, the first rash in dengue, the first rash which appears with fever or next day of the fever is never a prominent clinical sign. Where by the time patient comes to you, that transient rash is almost over. And it is not rash even, it is just a redness of, a generalized redness of palm extremities and all. So the first rash which comes in the dengue is not this child is not fitting into that. Anything about chikungunya? Would you like to give a thought about that?
Involvement of joint pain and bony pains are not there.
There was no any involvement of the joint pain at this moment. Okay. Yes.
This is the rickettsial. It's a possibility.
Okay. Rickettsia is always a possibility. Okay. Okay.
Is there any history of animal contact?
Is there any
History of animal contact.
any
Animal contact.
History of animal contact.
There was there was a documented history of an insect bite 8 days before.
One of the DD.
But on general examination, there was no issue. I have mentioned that in general examination.
Sir, but skin scrub typhus only the Ishtar is a classical finding, otherwise not.
Okay. So, can I invite my dear friend Atul, the doyen of fever and rash, to join the discussion along with our experts at this particular moment? So, how they will approach this child?
Yes, in this first thing is this child is having fever without focus, and there is a rash.
Okay.
Child is extremely irritable.
Okay.
Rash is having, as you said, the maculopapular rash, which is not extending over the palms and sole. Usually in the rickettsial and all this, you will get a rash on the palms and sole. So clinically, that is out.
Okay.
The all dengue, this is a 6-7 day of fever. So, right, no, 7 day of fever.
Yeah.
So, and child is still febrile and irritable. So fever is out. Dengue is not, we are not considering probably dengue. So this is not a dengue. So even other viral infections which are like exanthems, they should have either started regressing or they should settle down.
Excellent.
But here the child is still sick, irritable, fever is there, and incomplete presentation of can be Kawasaki. That can be one should think of, because
Sir,
there is one mode.
Arey, Atul ekdam down.
Sir, it's the team to crack the case, sir.
Sir, yeah,
Let the team crack the case, sir.
No.
Now the team, Atul, thank you for your valuable words. The team. Now, what about the bacterial causes of fever and rash in this particular case? Are you entertaining any bacterial causes other than rickettsia and all?
Unlikely to be bacterial, because by the time it has, ideally it should, with some treatment, it should regress, or either it should progress to a significant level. The main thing is, I want to ask about any prominence of BCG scar. Like,
very good. What you wanted to ask for the BCG scar?
Two things that since 6 to 7 days, the rash is more or less same. The child is irritable. Irritability is very significant.
Okay. So the points against bacterial infections are, in this case, as Atul has already told, by 6 or 7 days, the bacterial infection will definitely focalize themselves. So most likely a very close differential diagnosis in this particular type of rash, or maybe some other morphology like a sandpaper rash, when you have a cervical lymph node also, or when you have a throat changes also. The most common differential out of the bacteria could be a scarlet fever. But there are so many things against scarlet fever. There are so many things other which rules out bacterial infection at this particular moment, because there is no focalization. And the rash is same like that only, and the fever is still rising. So how do you start your workup, team? Actually, I need to answer that the BCG scar was normal. There was no any flare up of the scar. There was no any redness around the scar.
I think, just can I intervene, Dr. Sanjeev? Dr. Pramod Kulkarni, our chief coordinator, has a mnemonic for fever with rash. So,
okay,
can I invite him to just tell it?
Yes.
I think he has asked the team to mention the mnemonics. So I can tell you the mnemonic. Very sick people must.
Yes, please, Dr. Sharad.
Very sick people must take double rest.
Okay.
The fever with rash. Very sick people must take double rest.
Okay.
So V for varicella.
Okay.
Sick scarlet fever. S.
That's on the second day. So fever and rash on the second day would be scarlet fever. And rash on Thursday is varicella. Okay.
P for pox means smallpox. It is no longer there.
Okay. Third on the fever and rash on third day. Okay.
Fourth day rash appearing as all we know that measles.
Okay.
Okay. D dengue on fifth day rash.
Okay.
Usually, sir, I would like to interrupt. Usually, whatever rash on the day 6 or 7 you get in dengue is typically described as a white island in the Red Sea. You get whatever you get purpura, redness, and then you have the areas which are spared. So it is like a white island in a Red Sea. So this is not, the child is not fitting into that.
Not fitting in that.
Dr. Sharad is just enumerating.
He's telling the mnemonics, sir.
Okay.
Yeah, and Dr. Sharad, what about the last?
SICK.
R is rubella, then rickettsial fevers, all other things come later.
Okay. Thank you so much, Dr. Sharad.
So team Latur, how do you start your workup now?
Basically,
can I just intervene? And do they have any differential diagnosis so far? Does team have? Yeah, please your list of
non-responding fever. We should think of immunological causes like Kawasaki diseases.
First possibility Kawasaki. Second,
vasculitis.
Okay.
Yeah. So you are thinking of Kawasaki.
No, the point in favor of Kawasaki. What are the point in favor of Kawasaki from history and general examination?
irritability.
Yes.
Fever 5 days.
Irritability and fever is persisting like with temperature.
And conjunctivitis. Conjunctivitis is there and lymph node, although it is single, the lymph node is there. So all this.
But if you consider a complete Kawasaki syndrome, we are just fulfilling only 3 criteria of the principal cardinal clinical signs of Kawasaki at this point. So would you still think Kawasaki, or would you like to have another differential diagnosis at this particular moment?
Have a differential, but Kawasaki is like a spectrum. We may not see like a full-blown Kawasaki always.
Okay, it's a spectrum.
Okay.
So
can this be a MISC?
Okay.
Can this be a MISC?
Very nice. Who told me MISC?
I am just asking.
अतुल तू आता तुला जेव्हा बोलील तेव्हा तू बोल.
I am just asking them. Can it be MISC?
Yes. You asked team Latur. Yes, team Latur. What are the points in favor of MISC?
High grade fever.
Yes.
Rash more than days. WHO definition is there, and then laboratory findings. There is no other, and more than 2 system involvement. Skin involvement is there.
Okay. So from the examination point of view, the points against MISC will be now almost the epidemic pandemic is over. So we are not getting clustering of those cases. We are getting sporadic cases, of course, which could be one of the possibilities which we can entertain. But the typical age was MISC was minimum age was 4 to 5 years, which we have in our case series. Usually MISC used to have some other symptoms like GIT symptoms also at a higher age group, not at the age of 2 years. Of course, we did have a neonatal MISC as well, but that was a different spectrum altogether. So at this particular point, MISC could be one of the possibility, or basically what MISC was, it was nothing but a KD phenotype only. Okay. So workup, Dr. Team Latur.
Dr. Sanjeev, they have thought of Kawasaki, they thought of MISC, any other third possibilities?
Any other Latur team?
Soji like systemic contact juvenile idiopathic.
अरे काही तर बोला, त्यांनी ड्रग घेतलेले आहेत इन्सेक्ट बाईट साठी.
Drug rash can be the possibility.
Could it be a drug rash?
Drug rash can be, but
mucosal involvement.
Fever
okay,
of
palms and so on. Okay, okay.
high grade
I
persistent
thought they were
fever.
telling this.
Okay.
Dr. Srinivasan, you want to say something?
But they mentioned dress, DRES.
Yes. Okay, dress symbol. Yes, yes, yes. Okay. So, sir, your
Mentioned it. That's why I thought no, somebody mentioned it. Dress syndromes. I heard it
Yeah.
as dress.
Yes,
Okay.
yes, yes. So our other expert, Agar Khetskar sir, would like to have some comment on this stage. Okay. Okay. So workup, team Latur, start your workup now for this case.
Hemogram, CRP, the inflammatory titers like.
Okay. अरे पहले CBC तो करशील ना?
Oh, hemogram, I told hemogram.
Okay, 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 okay. Okay.
Like to have a complete blood picture like CBC with peripheral smear and ESR, CRP inflammatory markers we would like to do.
Okay. 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 So this okay. So this was the first line workup on 28th of the May. Hemoglobin of 20.5 at TLC slightly raised, total count with a neutrophils of 60 and lymphocytes of 28. CRP 12.2. There was SGPT was slightly raised. Urine was normal, same for culture. COVID antibody was negative. Dengue, ELISA was negative. Scrub typhus, the antibody test was negative. PS was not very much contributory. Blood culture was sent and awaited. And child was started on IV fluid and oral doxycycline at this particular point. So your comments, please, on this. This was on the day of admission. Okay. So our dengue is out, scrub typhus is out, rickettsia is out, MISC chances are lower down, and
why doxy?
So why doxy started? But there is always a good to give a therapeutic challenge in this particular case scenario. I don't know whether I was rational or not, but usually if in 48 hours if the rash and fever respond, it melts on doxy. My diagnosis is confirmed. But we did in this particular case, there was no any other reason to start doxy. Now the workup, the child was, the intensity of fever was rising, and the rash was also progressing. So the workup was repeated on 29th of the May. So your comments, Latur, please. What changes you are finding now?
Looking at the CBC, there is a slight rise in total count, which is suggestive of either infective or inflammatory process.
Okay.
The HB is on lower side, but it's okay. Then platelets are in the reasonably normal range. So,
but they are rising. They are rising. Platelets are rising.
They are in the second CBC. CBC.
Yes.
Talking about the first CBC.
Yeah. CRP has risen.
Yes. CRP and ESR is also markedly raised.
Okay.
Suggestive of more of inflammatory process.
Okay.
MISC already have ruled out. Serum ferritin is also in not that higher range. It's okay.
Okay. Okay.
And now clinical features arise again showing red conjunctiva, throat is normal, cervical is increased.
Okay. Okay. So fingers and toes are normal.
Okay. Immunological cause.
Okay. So what is your now you are now closing down to the diagnosis? Yes. Yes.
Joint involvement. Is there any joint involvement, sir?
Joints were normal. Today there were on 29th of the May, joints were normal.
Like the fever, which is more or less since 5 to 6 days persistent, with involvement of like conjunctiva, lymph node is increasing, the platelets are increasing from first to second CBC with increasing inflammatory markers.
Okay.
And being the COVID antibody is ferritin normal.
Okay.
And mostly when the child is irritable, the fever is still not responded. So
Less than 5 years. More.
So what is? So you are zeroed down on what?
Zeroed down on mostly like an inflammatory process. Would be most probably considering this age and other parameters would be most likely Kawasaki problem.
Okay. So would you like to put another word to the diagnosis of Kawasaki? What type of Kawasaki you are dealing with at on 29th of the May? Okay.
Incomplete form or
incomplete Kawasaki. So the diagnosis was made Kawasaki, most likely an incomplete one. The other differential, of course, was MISC. But on laboratory wise, on the peripherals near only, you can rule out in this patient MISC that MISC used to have a significant lymphopenia and also used to have thrombocytopenia from the beginning. So MISC, and since the COVID antibody was also negative, so almost we have ruled out MISC in the child. Of course, when you make a diagnosis of Kawasaki, the first and foremost important investigation imaging you do is 2D echo. Yeah. So what are the acute cardiac signs which are there in the acute condition of Kawasaki? Team Latu.
Acute condition may get pericardial involvement, pericarditis. Sometimes myocarditis also can be there.
Okay. Okay.
Features of CCF.
But the most important thing is the coronary size.
Dilatation or prominence of coronaries.
Okay.
That may appearing late in maybe second or third week. Sometimes maybe disproportionate tachycardia will be the only finding.
Okay. So now on examination, we have history-wise we have fever of 5 days. On examination, we have 3 important principal cardinal signs of which will suggest Kawasaki like rash. We have a lymph node and we have red eye. Okay, these 3 signs. So we are labeling it as an incomplete Kawasaki because we also have a substantial proof from the investigations like CRP raise, ESR was high. There was a mild transaminitis. There was lower side of the albumin was on the lower side. So we are nearly, this case is nearly fitting into the diagnosis of incomplete Kawasaki. So on 29th of the May, we have done an echo. So next echo, when you are planning, Dr. Team Latur?
I want to remind that there are just 5 minutes more. We
Okay.
have to wind
Okay, madam. I will wrap up quickly. So when you are planning the next echo. So there are different protocols to do echo when you suspect an Kawasaki, especially an incomplete one. An incomplete Kawasaki would like to have more predilection for coronary involvement than a complete one. Okay.
If the coronary involvement is there, mostly after the third IUI was completed, third day, we have to repeat today.
So the best thing which we have done for this child is on day 6 of the fever, we started injecting IVIG in the dose of 2 gram per kg, and that was completed within 24 hours. Your comment on this? Any expert would like to join me on this?
Yes.
Continuous because that was the window of opportunity for me, and
absolutely.
I did not want to lose that window of opportunity.
Absolutely, you must always give at the minimum suspicion you have to give because it can be life-saving.
Okay. Okay. And continuous infusion of IV immunoglobulin 2 grams per kg will be definitely useful in such case. Okay. Sir, there was a dramatic response to IVIG. Fever subsided, rash melted. And so we started on oral aspirin. So anybody from the Latur team, what is the current concept of putting which particular doses of aspirin would you like to continue in a child of Kawasaki?
1 day.
5 mg per kg.
Which dose? 5 mg per kg. Now the current evidence says there is no longer the 30 mg per kg for initial 1 week or 4-5 days, and then followed by 5 mg per kg is no longer a practice now. You can definitely start with low dose, only 5 mg per kg. But the story is not over, friend. कहानी में twist है. अगर इतनी simple Kawasaki रहती थी तो मैं present नहीं करता. Okay.
That's great.
Okay, so this is about Kawasaki. The last line, the mnemonic, crash. My Kawasaki bike has crashed and burned. C is for conjunctivitis, R is for rash, A for adenopathy, S for strawberry tongue and oral changes, H for hand and extremity changes, burn is for fever. So my Kawasaki bike is ulti-pulti now, burnt and crashed. So this is the mnemonic for Kawasaki. So very classical picture of Kawasaki, complete and incomplete both. So incomplete Kawasaki we have already discussed. We had this investigations were favoring and also the clinical sign. Recently, there are 2 urine protein biomarkers.
Dr. Sanjeev, I have to request you to finish in 2 minutes because we have the other team to present.
Can I borrow 3
The
minutes?
theoretical discussion can be done later,
No,
sir.
I think we can. Yeah,
we can
please
stop
go
here.
ahead with
Yeah.
the diagnosis.
This is the timeline of the KD. The first week, second week, third week, very classical, and this is the HA protocols for evaluation of incomplete Kawasaki disease. Okay, and this was the child before IVIG and after IVIG. Now on 3rd of June, the fever recurred and there was an evening rise with rash. So work was repeated. Today we could find CRP almost in the same range. Ferritin was sky high. ESR was 78. Platelet has gone up. Montoux was negative. So the diagnosis of partially responded KD was done. So again, Latur, what do you do at this particular moment now? Or my expert also can come in for this partially responded KD. Because the inflammation is still going on, the markers are high, ferritin is also high. Yes.
Can start like.
Sir, what intervention you would like to do at this particular moment? Anybody of you?
Maybe oral steroids followed by.
Hello? Yeah, somebody mentioned
Oral?
steroids.
Hello?
Interleukin 6 you can try.
So
Yes,
we need to
one by
wrap
one,
up, sir.
please. One by one, please. One by one, please.
Soshi, sir, we need to wrap up, sir.
Madam,
Can you...
Dr. Atul we have already spoken in the morning. He don't have a much longer case for 45 minutes. He will wrap up early.
No,
Just 2
we are
minutes. Give
already
me.
running late, Dr.
Sir, we are running
Okay.
late, sir.
Okay.
Can you please wrap up?
So
Yes.
anybody wants to join? Okay.
No,
So I will
Dr.
sum up. 4th
No,
of
no,
June,
Dr.
the child
Sanjeev,
has left.
Dr. Sanjeev, we have to give the team a chance.
Okay.
Give their final diagnosis and if there are any more clues so that they can come with the final diagnosis.
Okay. So the clues are as follows. On the 4th of June, the child had left knee pain, started limping, but there no any other joint involvement. But dramatically, On 3 to 4 days, the limping improved. So we consulted a rheumatologist on teleconsultation. On 8th of the June, the second dose of IVIG was started. The rash and fever subsided, but this time it was followed with 10 mg per kg of methylpred for 3 days, which is the part of race trial. After 3 days, oral steroid was started, continued for 2 weeks and tapered for another 2 weeks. 2D echo was normal at 4 weeks of the illness also, but the markers were still sky high. Ferritin slightly diminished, but CRP was increasing and ESR was increasing. Count was also increasing. So at this particular moment, would you entertain a possibility of a condition like macrophage activation syndrome, or we are dealing with something else?
Possibility of HLH or simply inflammatory process.
HLH or macrophage, same thing, sir. One and the same thing. So would you like to entertain these two possibilities, considering the blood reports on 10th of the June? ESR 92 count high. Sir?
Must always be considered, yeah, as a possibility.
But sir, the issue is that when we entertain HLH or macrophage activation syndrome, when at least we should have 2 cell line down, like by pancytopenia, then the ESR actually should decrease because the HLH and macrophage activation syndrome,
that is
they have associated decreased fibrinogen. So ESR should have gone down. So, and the total count at least should have shown something, or at least thrombocytopenia should have been there, and ferritin should have been sky high. So macrophage activation and HLH was practically ruled out with this.
Dr. Sanjeev, can we give the team a chance to say something? You want to say something? Yeah.
So team now, you want to say something?
I think Dr. Kiran has raised his hand. Yeah.
This is the persistence of same inflammatory process. It will take some time.
Yes.
So we may need to give immunosuppression for a longer period of time, or we can think of some other alternative immunosuppression.
So can we just wrap this up, and can team lab just come to a final diagnosis, and we'll have to wrap up. So please.
Like a 2 years old who presented with like initially with a fever with rash, more of irritability without any specific localization. Started with like an incomplete Kawasaki, progressed to complete one, and who required like maybe 2 doses of IVIG, and at the end of that still the inflammatory markers are high. We may need to give him the immunosuppression for some longer period of time and to watch for their inflammatory markers periodically till it normalizes.
Yeah. So
the other rheumatological conditions we started to rule out.
Dr. Sanjeev, can we give the experts a chance to speak?
Yes.
Finish
Sir,
the
experts are on this slide.
Yeah, Dr. Atul, please.
Please,
Yeah.
Dr. Sanjeev, can we give Dr. Srinivas a turn to
Yes.
Yeah.
Srinivas.
Scene is very, of course.
I think we can
subject
stop.
of Kawasaki disease, but then of course.
Just a minute. Can we stop screen sharing, Dr. Sanjeev? I think we have wrapped up, and we can.
This is last slide, ma'am. This is last.
This
slide.
is last night, so we stop.
And I would like Dr. Srinivasan sir to comment on this slide.
Yeah. With especially development of arthritis, etc., we must consider. And of course, as you have mentioned, we cannot think of the cell lines are not down. So naturally, we have to think of systemic juvenile rheumatoid arthritis in this case.
Very good.
As a very, because they can also have rashes in the beginning and high fever.
Yes.
Okay.
So the most likely possibility of this child, which we have zeroed upon, is a systemic onset JRA, considering that the inflammatory markers are still high. Arthritis may be there after 2 to 3 weeks. Only you can have fever and rash. Presentation is just like Kawasaki in the first 2 weeks when you consider the diagnosis, even in SOJRA. And these are the take home from this case. Every fever is not infection. If rash is not classical of any viral or rickettsia or drug induced or urticaria, follow-up and workup is needed for non-infective causes of fever. High index of suspicion for Kawasaki should be kept. After ruling out differential, IVIG has to be given in the first 10 days if suspected KD. Commonest cause of rheumatological HLH or MAS is in pediatric is systemic onset JRA or KD. So finally, we have zeroed upon the
Thank you.
diagnosis of systemic onset JRA in this child. Thank you, sir.
Thank you so much.
Actually,
And,
only
Team
thing we have to
Latur-
wait for 6 weeks before we can totally label
Sir,
it.
the
Yeah.
6 weeks are already over in this child now.
Yeah, that's true. Yeah.
Okay.
Thank you so much. And thank you so much, Team Latur. You were very close. You said it was an inflammatory disorder. And of course, it was only over a period of time. So well done, Team Latur. Your clinical approach was good and a very good case, Dr. Sanjeev Joshi. Thank you, Dr. Srinivas and Dr. Sharad for your comments, and Dr. Atul Kulkarni. So
Thank you, Team Maharashtra IP. Thank you, Srinivasan sir. It
Okay,
was
I
a
think
great. You were
this
a
will-
great asset here.
thank you. We go
Not at
to
all.
our
Thank you,
next
sir.
case.
My privilege
Yes,
to
sir.
attend and learn.
Yes.
Thank you, sir.
Yeah.
So let's start. We are already short of time.
Yeah.
So let's start with the second case, and I hope Dr. Atul Jhawar is in. Dr. Atul Jhawar, are you ready?
Yes, he is ready. Yes.
Yes. Yeah.
So you can start
Atul
with
sir.
the Atul sir. You can start with the share
I will share
screening
my
the.
screen. No? My voice is audible, no?
You can.
Yes, you are audible.
If there's a problem, you can just keep your video off. And Team Thane, please be ready.
Yes, make it a full screen, sir.
Team Thane, you are ready? Dr. Sudham, Dr. Rishikesh, and Dr.
Yes, yes.
Smita.
Yes, Smita is there.
Okay.
Yes.
Yeah. So all the best.
Thank you. So make it a full screen.
You can make a full. Yeah. You can make it full screen.
Yes.
Sir. Yeah. It's visible.
Please start.
It's visible and audible also, no? You can start
Yes. Yes, sir. You can start.
Myself, Dr. Atul Jhawar. I'm pediatrician and neonatologist at Solapur. So without wasting much time, we will start the case. My case is a case of newborn. Uh, uh, Initially, I want to explain that I'm working at a tertiary care center, which is a perinatal center, Unique Hospital. And we have Dr. Ajit Gandhi, sir, our gynecologist, and he's a fetal medicine specialist also. So with his collaboration, we have done this case. This case this baby was delivered preterm at 31 to 32 weeks, normal vaginal delivery. Baby's birth weight was 2.680 kg. Few antenatal history I will like to mention at this point. This mother, she is a 23-year-old primary gravida. There is no history of consanguinity, no history of diabetes or hypertension, and she was referred to our center, to our gynecologist for a second opinion for polyhydramnios and fetal ascites. So at our center at Unique Hospital, they confirmed the case and confirmed this findings on ultrasound, and amnio reduction was done. Almost 2 liters of fluids was removed, and even fetal ascitic tapping was also done at around 24 to 25 weeks of gestation. And at this time, there were no any finding of fetal anemia, and the GTT was of the mother was also normal. There was no any glucose intolerance. And after 1 week, there was repeat amnio reduction was done, and ascitic fluid tapping was done on the second time. So 2 times there was ascitic fluid tapping done in the antenatal period. And then this mother delivered at 31 to 32 weeks. There was a preterm delivery, and of course, baby had some respiratory distress at birth, and baby was shifted to NICU under my care. Anything else you would like to know at this point in the history?
Whether stomach tube was able to pass or no?
Yeah. Their patency was there.
Mother's blood group. Mother's blood.
Blood group, I don't remember exactly, but there was no any signs of fetal anemia. So, and indirect food states were also negative. So, it was positive group only. I'm sure, not sure, but it was positive group, not negative, not RS negative.
I would like to ask history of maternal infection. In today's era, non-immune hydrops is much common than immune hydrops.
There were no signs of fetal anemia. So hydrops we cannot. There was only fetal ascites was there. There were no any signs of fetal hydrops, and of course there was no any history of antenatal history of any infection to the mother like fever, rash, or any joint pains during the antenatal course. BP and
VDRL was
sugar.
done. Mother's VDRL
Yeah,
was done.
yeah. That was routinely done and it was negative. Anything else? We can proceed.
Yes.
So this baby was shifted to NICU. On general examination, a few points I would like to mention. Baby had a gross facial feature and there was macroglossia and the abdomen was distended. Liver was palpable around 3 to 4 centimeter. And baby had RDS. There was reticulogranular pattern with air bronchogram. And we started on nasal CPAP. Baby required nasal CPAP for 3 to 4 days, followed by oxygen support for another 4 or 5 days. But luckily, baby didn't require any surfactant. With nasal CPAP, baby improved the respiratory distress. Then in NICU stay, at birth, baby had hypoglycemia on day 1. Initial blood sugar was only 20 mg per deciliter. We started on the at 4 mg per GDR, but baby had a persistent hypoglycemia. We had to escalate the to 10 mg per minute. And even after full fades, like on in day 15 or 16, there was persistent hypoglycemia, and we needed steroids also for correction of the sugars. We could achieve the normal sugars only after 3 weeks of life. Anything else you want to know?
Could we do the insulin levels when there was?
Yeah. I will come to that.
Okay,
All the investigation, it was done and all were normal. Like all the reports, I will mention in the next few slides. I'm just mentioning the course in the NICU. Then baby had, I already mentioned, baby had distended abdomen and there was palpable liver and kidneys. We started nasogastric feeding from day 2, but on day 5, baby had some feeding intolerance. That was, I think, because of sepsis and early NEC. Sepsis screen was positive, which improved after escalating the antibiotics and other supportive care. And again, we could restart the feeding after day 7, and we could achieve the full feeds on day 12 of life.
Any differences, Steve Tane?
Yeah, here baby is 31, 32 weeks and weight is slightly higher. We can say LGA baby with hypoglycemia almost for 3 weeks of gas duration associated with macroglossia and some facial abnormalities, dysmorphism.
Yes.
So these things to be kept in.
One thing which is coming into my mind when macroglossia and hypoglycemia came, what was the cardiac function like?
Yes.
Cardiac function was normal. We didn't do the echo, but baby doesn't require any inotropic supports in the NICU.
Is there any hemi-hypertrophy like pictures in babies?
No.
General examination.
Let's first discuss the.
I will show the clinical picture of the baby. Yeah. We can go ahead with the further announcement. Baby had one episode of seizure that was because of hypoglycemia, which got corrected after giving the sugars. And we did ROP screening also that was showing early AP-ROP changes. That was a routine protocol. So after 28 days of NICU stay, we could discharge the baby on full oral feeds with normal sugars, normal maintaining temperature, no signs of sepsis, and adequate weight gain on full oral feeds. So there are we would go for the investigations.
Yes.
Or anything else you want to know at this point? Or
any liver parameter? Liver parameter.
Yes, sir. This is a preterm case. Yeah. This is preterm case with LGA baby with dysmorphism and associated with hypoglycemia. I would like to screen and associated with respiratory distress syndrome. First, I would like to investigate commonest condition like sepsis. Early onset sepsis is there or not? Basic workup to rule out early onset sepsis associated with.
It was there. It was there.
And depending on that just initial antibiotics, basic antibiotics and ventilations, these things and hypoglycemia management, these things will keep in mind and monitor the babies.
What are the investigations you would like to do here?
Yeah, in investigation, CBC. Hello.
Can others please mute it? Can others please mute themselves? Yes, please. Team Thane, you can continue. Yes.
Yeah, CBC to look for is there any
anemia,
hemoglobin anemia,
and
then
sepsis,
leukopenia or thrombocytopenia to rule out the sepsis. Then we'll see CRP after 12 to 24 hours of birth. If 2 CRPs are negative, we can say it's sepsis screening is negative. Then I would like to send blood culture also and empirical antibiotics to cover for both gram positive and gram negative organisms. We have to start.
Apart from sepsis, any other differential do you have?
X-ray to look for cardiomegaly, because I am thinking of Pompe's. LFT is SGPT, SGOT, and
very
CPK
important
total
question,
and
yeah.
CPKMB. LDH,
Yes.
CPK total, CPKMB.
Okay.
Yeah, macroglycia with hepatomegaly with this thing, you are correct, madam. You have to look for,
And also USG abdomen as antenatal history was suggestive of ascites.
So we will see
GSD is also one of my
GSD is
differentials.
like
GSD is also
post
one of
facial
my differentials.
Which one? Pompe's
glycogen storage disorder.
Glycogen storage.
Okay, so the differentials here for you are either GSD or a sepsis.
Sepsis, GSD, Pompe's, and we would also like to rule out as we previously said, what was the insulin level? So any hyperinsulinism, which it could be a syndromic baby with hyperinsulinism, or a syndromic baby with hormonal abnormalities which has caused the hypoglycemia.
Dr. Atul, can you go ahead with your investigation?
Beckwith-Wiedemann syndrome. You're thinking of Beckwith-Wiedemann syndrome?
Yes, sir. Beckwith-Wiedemann.
Yes.
Okay, so I will show you the investigations on day wise. On admission, I told you already there was hypoglycemia. Initial CBC was almost normal, like HB was 15.4, WBC and platelet were normal. On day 6, when baby had symptoms of early sepsis, we did CRP, it was positive. There was slight hyponatremia, but potassium, chloride, SGOT, SGPT all were normal. Baby had slight jaundice, which improved with phototherapy. Creatinine was also normal. Then in view of persistent hypoglycemia, we worked all this. Insulin level we did, that was normal. Cortisol levels also we did, thyroid and ammonia. All these basic investigations were normal. There was no any acidosis also.
So Team Thane, your comments on this investigation?
Here, insulin was done at the height of hypoglycemia, or is this the random insulin level?
Random insulin. Because baby was on continuous glucose drip.
Basically, Dr. Atul, would you like to test for urine whether it was a ketotic or a non-ketotic hypoglycemia?
Right, sir.
Yeah,
So urine
because
also we need to
that
set.
will altogether will make a good choice for your battery of investigation for the next investigation. You can decide the battery of investigation depending on whether it was a ketotic or a non-ketotic hypoglycemia.
Yes.
Even ammonia seems to be a borderline level, not very high also, but not normal also.
Yes.
And one thing, Dr. Atul, you have given steroid in the first 3 to 4 days to maintain normoglycemia. Is it a standard practice when you are dealing with
I think Dr. Sanjeev, Sanjeev, we should not discuss.
Okay.
And the team discuss.
Sorry.
What was the ABG? Any acidosis was there?
Hello.
Yes, sir.
He's joining again. Yes. He's joining again. So please wait. Dr. Sandeep Kadam sir is there. He's a neonatalist from KM. So, Sandeep sir, yes.
Yeah, very interesting case actually. They are in the process, so I would not like to.
Yes.
Yes, yes.
True, that's true. Yeah.
Atul sir came. Yes, came
Can
back.
you just analyze up till now, sir?
Yeah,
Sandeep sir,
basically this is a 29 to 30 weeker, large for gestational age baby with fetal ascites and polyhydramnios. I think these are 2 or 3 important factors which we need to understand. And also on examination, this baby had slight coarse features
Yes.
with hypoglycemia and a large for gestational age baby. I think these are some of the things that we come across with a persistent hypoglycemia. So basically, what it is telling us that it took them 3 weeks for maintaining a normoglycemia or euglycemia, requiring fairly high glucose infusion rate. They had to go up on the glucose concentration. So where are we in terms of our diagnosis? I think the approach would probably be, is it metabolic or is it a genetic disorder that we are looking at? So let's wait for the further details.
Yeah.
Yes, yes. Atul sir, please, sir.
There is definite evidence of hyperinsulinism. Yeah.
The insulin which is detectable with the presence of a low sugar, it indicates that the insulin was probably high, but here we
More
don't.
than 2 is considered to be abnormal, right, sir?
Yes, and we don't know what the corresponding glucose was. So probably it would not be fair for us to comment about this insulin report. And as rightly said, I think we should have done ketones to find out whether it was a hypoketotic, ketotic hypoglycemia. I think that would change our thinking, because if it is hypoketotic, it is either hyperinsulinemia or free fatty acid oxidation metabolism or beta oxidation defect.
Yeah.
Dr. Atul,
Ketones, yeah. So with this, what we can suggest, like, what are the DDs with this all these investigations? I think that this is a preterm baby. There was RDS, there was sepsis,
Yes,
and there was hypoglycemia.
Yes, with this is a case of preterm LGA RDS with persistent hypoglycemia of infancy with dysmorphism.
With hyperinsulinism, possibly, and with fetal ascites and fetal polyhydramnios.
And another thing, ultrasound I didn't mention. I think ultrasound was showing hepatomegaly and nephromegaly also. So there was large kidneys in this baby, and that was this finding was also present in the antenatal scans also. Like there was fetal ascites.
I will consider more favor in terms of Beckwith Wiedemann.
Sir, I am not sure, but whether mucopolysaccharidosis presents as a fetal ascites or not, I am not sure. But other features can go with that.
Antenatal scan as suggestive of nephromegaly and hepatomegaly. I will consider 2 conditions.
Is important, yeah.
One is Beckwith Wiedemann and other is congenital nephrotic also should be keep in mind.
But also ask our experts to give some comments regarding.
I already mentioned, madam. I have told about this thing, condition. So we initially thought of this thing, Pompe, then of course Beckwith-Wiedemann syndrome and hyperinsulinism due to glycogen storage disease type 2. These are the 3 possibilities I was thinking of in my mind.
In this discussion, Sandeep, excuse me for a minute. In this discussion, the core species and this thing was mentioned, and none of the IEMs present with a core species except for MPS, as she has said. MPS can have core species, but there is a distinct organomegaly with ascites. There is a large kidneys and liver.
Sir,
so again, organomegaly with hypoglycemia. So I would like to go for a diagnosis of Beckwith-Wiedemann syndrome.
That's what I thought, because once you mentioned that this thing, most of the organs are enlarged, so naturally we have to think of that. Core phases, tongue, put together, I think first diagnosis of mine will be Beckwith-Friedman syndrome. Yeah.
Sir, can I make one more point?
Yes.
Was
Yeah,
there any
please.
significant anemia in the baby? What was the HB? I forgot.
No, HB was 15.4. There was no any anemia.
No significant anemia, because otherwise anemia, organomegaly, and hydrops fetalis could also go in favor of storage
But
disorders.
even antenatal scan also I mentioned there was no any signs of fetal anemia. There was no hydrops. Only fetal ascites was there. There was no like NSR.
So one more thing that comes here is that, I mean, all of us agree that it could be a storage disorder, but ascites is something which probably one is not very common with a Beckwith-Wiedemann syndrome. You would get coarse features, you may get a large baby, you may get
not often reported. Yeah, occasionally it can be.
This is probably heading towards some other etiology, like it may be something to suggest that there is probably something which is not coming out with a clinical picture. There is evidence of hepatomegaly in ascites. Is it a liver disease which is causing ascites and the kidneys are enlarged? Ascites is not going very well with Beckwith-Wiedemann. So,
Yeah,
was
this is
there any ascitic tap done or investigated for?
It was done in the antenatal scan and it was turned out to be transudate. And at the same time, DNA was preserved. As you have correctly mentioned, sir, because in Beckwith-Wiedemann, I think there is no fetal ascites, only organomegaly we can see. So the first possibility was kept as a storage disorder only. And
Yes.
in view of that, only the DNA was preserved. I will come to that. Like, if you want, I can go
one
ahead.
of the lysosomal storage disease that can present with hepatomegaly, coarse features, kidneys which are enlarged. Sometimes there is a cardiomegaly. But I think looking at the baby and clinical presentation, maybe we could get some clue. Are we looking at a lysosomal storage disease also?
Atul, sir? Yes, sir. The microarray was sent in view of that only, but it turned out to be negative. There was no any lysosomal storage disorders. And even in the initial
Microarray may not be able to pick up a.
the whole exome sequencing was also done, and it came negative also for Beckwith-Wiedemann also. But with this, all these findings of nephromegaly, macroglossia, and neonatal hypoglycemia, we sent for methylation specific duplication analysis, and that finally came positive for Beckwith-Wiedemann. I will go ahead with the reports. Is it okay? Yes, sir. Yes. So these were the fluids, and these are the clinical pictures of the baby. There was crease in the
ears are typical of Beckwith.
yeah.
Beckwith, yeah, therapy.
Yes, sir.
Yeah.
Yes.
And this was the initial X-ray showing some RDS features and hepatomegaly also. So this was done. Initial microarray whole exome sequence was negative for Beckwith-Wiedemann also, but this methylation deletion report that came down positive, and the chromosome was saying that there was uniparental disomy of the region of 11p15. That was confirmed. Thank you, sir. Can you stop sharing?
Sandeep, what was the cause of ascites?
Okay. In this, was it?
Because see, Beckwith-Wiedemann will not present with ascites. All the other features would definitely fit in terms of persistent low sugar, high insulin, dysmorphism, large baby, large liver, large kidneys, transverse crease of the ear lobule. Was there any hepatic vein Dopplers or anything to suggest that there was evidence of any liver dysfunction? What were the serum proteins?
Sir, we should also do 2D echo, right?
Yes.
2D echo was normal, sir. Later on, we have done like on the follow up, and that hepatic Doppler definitely we are not done. but these hepatic parameters were normal, sir. Like LFTs were only there was some hyperbilirubinemia. I have already mentioned that HCOT, HGPT was normal.
What was the renal function?
Renal function also, we had done the creatinine, that was also normal, 0.4. But that was in the initial period. We have followed the baby up to 2.5 months. Till now, there was no any findings like.
Now I checked this thing. Can I tell?
Yes,
Just
sir.
now, after he mentioned, I put ascites in Beckwith-Wiedemann syndrome. In 2014, there is a fetal ascites has been mentioned. And so I can show you this. Okay. Just I put no Beckwith-Wiedemann syndrome. Okay, with ascites. So that is this thing neonatal medicine, Journal of Maternal Fetal Neonatal Medicine, October 2014.
Okay.
Because other things, were very typical year after showing. So this is mentioned in 2014 in Journal of Fetal and Neonatal Medicine.
Wow. That's good. So I think that was a very good case, and just with a typical manifestation and a very good tracking by the team Thane. They almost went to the diagnosis. So yes, congratulations team Thane, and also a very good case presentation by Dr. Atul. All the time.
Deepa.
Yes, R.D. Patil, sir. Yes, sir.
Yeah, I just wanted to have few queries to Atul. Did it any time mention about unilateral kidney size, whatever was mentioned? There was a nephromegaly, this is for nephromegaly. Was it any chance of unilateral enlargement?
No,
or
sir,
whether
no.
one kidney was bigger than the other?
No,
Because
sir, there
here,
was,
here, as someone has said, that hypoglycemia with coarse faces. It is very rightly somebody said that we rarely get any coarse faces. So hypoglycemia with coarse faces, LGA baby. I think clinically you must be sending the whole exome sequencing for 11p, whatever deletion which you have suggested, which will fetch the diagnosis of Beckwith-Wiedemann. But unilateral organomegaly or this thing, unilateral this thing, that can definitely give us a clue that this was probably Beckwith-Wiedemann syndrome.
Just wanted to make one comment.
Yeah, please.
Yes, sir.
I think what has happened here is I just read that article. You have presented as a Beckwith-Wiedemann syndrome, which is clearly fitting in, but there is associated Perlman syndrome, which is an overgrowth syndrome with high perinatal mortality, which has polyhydramnios, macrosomia, visceromegaly, nephromegaly, and fetal ascites.
Okay.
So probably more typical of a Perlman syndrome with Beckwith-Wiedemann.
the whole exome sequencing was done, same, but it was negative for storage disorders and for Beckwith-Wiedemann also.
So what you can do is, along with the same picture, ask them to look for Perlman syndrome also.
Wolman syndrome, there will be adrenal calcification. If you take this thing, there's this thing, there is adrenal calcification, very characteristic of thing, and adrenals are very much enlarged.
Because
we had a case of this thing, episplenemegaly with Wolman syndrome with malabsorption in an older child.
Not Woolman, sir. Perlman. Perl.
Perlman. Acha, okay. Perlman. Okay. I heard it as well. That's what I was wondering. What? Thank you.
Not Woolman.
I haven't heard of this syndrome. I will go through it. Thank you.
Yes, sir.
No, I heard it in my ears, age. I heard it as
Woolman with Beckwith-Wiedemann. That is what they have presented.
Very pertinent suggestion by Dr. Pramod Kulkarni, which also came to my mind, was about placentomegaly. If somebody would have asked how much was the size of placenta, if large placenta along with this, since it was antenatally already visceromegaly was there, So placental size also would have given us clue
Those
about
days after
decussing.
delivery, every placenta weight will be taken and seen. But nowadays, nobody sees. I don't know about newborns. Yeah, previously when we were this thing house surgeons and the senior house surgeons, we are supposed to weigh the placenta and also mention the size and any infarcts are there, and also single umbilical artery we have to see very carefully.
Yes, we had thesis.
No,
based
but
on
in this
the
case was known already antenatally. There is nephromegaly. So that would have definitely made us to weigh the placenta or at least see the size of placenta. That probably would have given us a clue.
Yes. So yes, that was a great discussion, and we had two great cases today, and very well cracked by Team Latur and Team Thane. So
Well discussed. Yeah, by.
well discussed. So I think we can wrap up this discussion. Any comments from our experts?
Yeah, it's a learning experience. I am a learner, an eternal learner, so it's a learning experience. Each and every case has something to offer to improve your knowledge base. That's why I attend almost all these PG programs, etc. And I am not disappointed. I am very happy that I learned something more. Thank you so much. It was very well discussed and very well presented. And thanks to the organizers as well as the teams who have done a wonderful job. Last time also I was listening to Pramod Kulkarni with Bala in the platform, so I never miss it. Thank you so much.
Thank you very much for the opportunity, Maharashtra IP, Amol, and Dr. Ramakant Patil. And it was good effort by Thane team. They almost reached the diagnosis, and it was good effort. Thank you very much. It is a good exercise being conducted by Ramakant Patil. Keep up the good work. That will stimulate.
Many of the diagnoses will come only finally through advanced techniques.
Yeah.
So, but you have come very close to it, and
that is the most important thing. And important thing is to learn from all the cases. Thank you.
I would request Dr. Pramod Kulkarni to unmute for a minute and say whatever, because he has been so many chat messages, but he has never spoken. So please, Dr. Pramod Kulkarni.
He has always been like that. Even in the Apollo clinic, he will only put in the chat box. He'll ask him to comment.
Starts talking, then nobody else will be able to talk, sir.
No, please, Dr. Pramod.
Excellent cases and well tried Team Latur as well as Team Thane. And I will like here with the first case presented by Dr. Sanjay Joshi, follow this case up whether it is really systemic JIA or something else. SJI is the differential diagnosis, but will be confirmed as a diagnosis only after some time when the evolution of the disease will confirm it. Otherwise, it classically fits in SJI. So non-responsive KD, the first and only DD is SJI. This child classically, and just to remind you, 2 weeks of fever is sufficient to make a diagnosis of SJI. All
mentioned, sir.
Need 6 weeks, but SGI needs only 2 weeks of fever, which is sufficient. This child again would respond to steroids. I don't think there is any reason for this child to flare up again when the steroids were kept on. Only after tapering the steroids or putting them off, the course, how it happens, needs to be observed properly. That is the only contribution from my side. Thank you very much. It was very nice session. Thanks.
Thank you.
All
Thank
the
you
great
for
experts.
wrapping up it.
Thank you so much.
Thank you so much.
Thank you.
Thank you all participants. I request Dr. Neha, are you there?
Thank you all. Thank you all.
I'd like to propose a vote of thanks.
Yes,
because like an Agatha Christie thriller, you know, the plot thing. In the first case,
selection of cases are wonderful.
Yeah, and even in the second case, it took a twist, and we went. And both the teams, like Dr. Amdekar always says, it's not the final diagnosis, but the approach. And even the first team Latur made a good clinical approach towards immunology. Second team made a very good Beckwith-Widman. But then there is something more to learn, and there's always more to learn. And there is some Perlman syndrome as well. So thank you so much, Dr. Ramakant Patil, for bringing this back into the fore. What a wonderful platform for everyone. Dr. Amol Pawar for working so hard to get things together. To our chief coordinator, Dr. Pramod Kulkarni, who was only chatting away, and only in the final thing, he said a few words. And to our observer, Dr. Pustake, and what to say of our great doyens the clinical doyens of pediatrics, Dr. Srinivasan sir, thank you for joining us as expert today. Our second expert, Dr. Sharat Khedkar, thank you so much for being there. Both the teams did wonderfully. Thank you, team Thane, team Latur as well. And of course, our guest of honor, Dr. Atul Kulkarni, for all your words of wisdom and all your good work in Riketsya. We'll keep inviting you on our platforms. Thank you, Dr. Deepa Firke. I thank the whole Maha IAP team. I thank all the EB members who have joined us, EB members of Central IAP as well as Maha IAP. I thank all of our viewers who have been here. It's past 10, it's past most of our bedtime, but we are here watching this. I think it's more interesting than Kaun Banega Karodpati, because we are not going to be Karodpati in money, but definitely in knowledge, and that we have all learned today. And thank you everyone who has made this possible. Pallavi, Neha for always being there as backup. Thank you, Pallavi Dharmadhikari, for bringing this on the digital platform. And good night, and we meet again after 15 days in a similar Dhantadan cases. So please be there. And please don't join us only for the MMC points, but for all the points that you're going to pick up clinically. Thank you so much, and good night, everyone.
Good night. Special thanks to Dr. Sandeep Kadam, sir.
Thank you very much, Dr. Sandeep Kadam, sir. Like I always
Your inputs were very valuable, sir.
Very, very valuable, and he was so thoughtful. You know, he kept thinking about could this be, and he even did the last minute search on Perlman.
Perlman syndrome. Yeah.
Yes.
Yeah. Thank you for the
Good night,
wonderful
all. Good night, all
opportunity.
of you. Good night.
Good night.
Madam,
Good night, sir.
recording stop kara, madam.